Hey everyone, thanks for joining us at Medfoxes. You're watching advanced concepts in cardiac pacing, programming, and clinical applications. If you've already completed our beginner series on pacemakers, this next lecture is perfect for you. In this lecture series, we'll explore the real world side of things, how devices are programmed, how leads and sensors are selected, and how these choices impact patient care. To start, we'll dive into generator and lead selection, focusing on how to choose the right device components for each patient. At the end of each session, there's a short quiz to help you lock in what you've learned. Let's jump right in and get started.
Pacemaker selection today involves a decision as to whether cardiac resynchronization therapy is required. A significant proportion of patients receiving devices have combined abnormalities that may include chronotropic incompetence, atrioventricular nodal dysfunction, interventricular conduction delay, also known as electrical ventricular desynchrony, and the possibility for ventricular arrhythmia. Thus, decision of patient requiring pacemakers may involve consideration and exclusion of the need for a defibrillator lead or a left ventricular pacing leads. This algorithm can be used for pacing mode selections that include most available pacing modes. These algorithms can be followed for pacing mode selections that include only DDDR or VVIR pacing modes. Many algorithms have been used for pacemakers and mode selections. Although all rules have exceptions, a very simple approach is appropriate for most patients. For example, with chronic atrial fibrillation and a slow ventricular response in whom pacing is required, VVIR is a mode of choice. This is the only clear-cut indication for single-chamber ventricular pacing. Obviously, other patients may have associated comorbidities or other issues that would favor use of single-chamber ventricular pacemakers, either VVI or VVIR. For example, in patients with other irreversible medical problems, in whom longevity or activity level or both is markedly limited, a simple device may be most appropriate. This decision must be made individually. However, even in the most ill patient in whom a pacemaker is being implanted, one must be certain that a simple device, that is VVI, which does not make the patient worse by causing adverse hemodynamic symptoms, example in case of pacemaker syndrome. For most patients with bradyarrhythmias requiring pacing who do not have a chronic atrial fibrillation, a dual chamber pacemaker is indicated. Using a dual chamber pacemaker with rate adaptive capability in all patients provide the long term flexibility. In some situations, however, rate adaptive pacing is essential, including dual chamber devices placed specifically for patients with sick sinus syndrome and fatigue from documented chronotropic incompetence and patient with chronic atrial fibrillation with slow ventricular rate. Because rate responsiveness in patient with chronic atrial fibrillation depends on autonomic regulation of AV node, which is generally poorly regulated in these patients, necessarily requiring sensor driven pacing. For the patient with pure sinus node disease, that is, no documented or provocable abnormalities in AV nodal conduction, AAIR pacing may be appropriate if pre-implantation testing has established normal AV nodal conduction. In these patients, the annual risk of AV block developing is 1 to 2%. If AV block develop, another procedure is required to implant a ventricular lead and upgrade the pacemakers. These additional procedures may be avoidable if DDD or pacemaker is used initially. For the patient with pure AV nodal disease, that is, no documented abnormalities in sinus node behavior, VDD or VDDR pacing may be appropriate. Specifically, the patient with congenital complete heart block may do well with VDDR pacing. In pediatric patients, from a hardware perspective, use of single lead VDD or VDDR pacing systems helps to minimize the amount of hardware needed. The bradycardia that occur in patients with carotid sinus hypersensitivity may be due to either AV block or sinus arrest. Therefore, ventricular pacing support is required in this patient, and dual chamber pacing is superior. If a patient requires pacing for neurocardiogenic syncope, whether the vasovagal variety or carotid sinus hypersensitivity, dual chamber pacing is necessary for several reasons. In a patient with a vasovagal syncope, the most likely has some component of vasodepression together with the cardio inhibition that require pacing. Ventricular pacing alone could result in pacemaker syndrome and further aggravate symptoms caused by hypotension. Choice of pacing lead or leads become one of professional preference or personal bias. Choice of pacing lead should also based on the performance data of specific model. When choosing the lead, following must be considered for all leads. One is the type of insulation, whether it is a silicon or polyurethane or combination of both, and the mechanism of fixation, whether it is active fixation or passive fixation, and the polarity, whether it is a unipolar or bipolar. And also compatibility of lead and pulse generator connection system also be considered. When choosing an atrial pacing lead, following must be taken into account. One is insulation, fixation, polarity, and whether the lead is straight or with preformed J tip, and also intra-electrode distance. The intra-electrode distance of a bipolar lead also deserve consideration. These distance may not only affect the duration of intracardiac EGM signals, but also usually has an effect on the amplitude and sleeve rate of electrogram signals, depending on low and high frequency bandpass filter in the input amplifier of the devices. A lead with greater distance between electrode will generally have larger amplitude far field signal, that is R wave will may be sensed on atrial lead. These characteristics may affect the reliability of mode switching. You can see different form of pacing leads from left. Is a J tip active fixation lead, then a straight tip lead, which is also an active fixation, and the last one is a passive fixation lead which has tines on the tip. The another key property of pacing lead is drug elution. This is a diagrammatic representation of steroid eluting lead. The steroid is slowly eluted through the porous of platinized tip of silicon rubber plug. Steroid elution has been the most successful and most widely used method for threshold reduction. Steroid elution has been accomplished in several ways, such as from a steroid saturated silicon plug within the lead tip electrode, or from a steroid eluting collar adjacent to the tip electrode. Steroid elution significantly minimizes the post-implant pacing threshold increases and peaking that typically occurs with non-steroid eluting electrodes. The steroid eluting plug or collar contain a very small amount of steroid, example less than 1 mg of dexamethasone sodium phosphate or dexamethasone acetate, which do not have any systemic effect. Steroid elution is available on atrial and ventricular leads with both active and passive fixation mechanism, and also available in coronary venous or epicardial leads. Let's focus on compatibility of lead and generator. The pacemaker lead or leads and pulse generator selected do not need to be from the same manufacturer. It generally accepted to mix and match leads from company X with the pulse generator and company Y, assuming similar functionality. What is mandatory is that the lead connector be compatible with the connector cavity of the pulse generator. Historically, unipolar leads were 5 or 6 millimeter in diameter, and bipolar leads were the bifurcated design with a similar 5 to 6 millimeter in size. Most leads currently used are inline bipolar design with a 3.2 millimeter in diameter. In 1986, a voluntary standard for lead connectors and connector cavities was established. These voluntary standard for leads and connectors incorporate sealing rings on a 3.2 millimeter lead connector and is referred to as VS1 standard. Subsequently, as industry-wide international standard configuration known as IS1 or International Standard 1 was developed and accepted. Currently, virtually all pacing leads complies with the IS1 standard connector configurations. You can see in this slide, picture A shows variety of VS1 leads. The top diagram IS1 VS1 type, middle diagram 3.2 millimeter connector with sealing rings referred to as Cardis type. The bottom diagram 3.2 millimeter connector pin with sealing rings. Picture B shows available types of inline pulse generator headers. In upcoming slides, let's discuss on generator and lead selection in defibrillator. The lead selection for defibrillator is complex. It needs broad knowledge of lead properties. The transvenous defibrillator lead, typically placed in right ventricular apex, serve to sense signals, in other words, local electrograms. Pace the heart means anti-bradycardia and anti-tachycardia, is also known as ATP, and deliver shocks. ICD leads are tripolar, tip and ring electrode with one coil, or tip electrode with two coils, or quadrupolar, tip and ring with two coils, with variation in distribution of function across these electrodes. The true bipolar sensing occur between the tip electrode and a closely spaced dedicated ring. Since the spacing between these bipolar pairs is small, far-field electrogram for noise related to lead interaction or electromagnetic interference is less likely to be sensed. On the other hand, integrated sensing lead systems are constructed with a distal tip electrode for pacing and sensing, a distal coil for both pacing and sensing and for defibrillation, and a proximal coil for defibrillation. This design has the advantage of incorporating two defibrillation coils, which in conjunction with an active CAN device, lower defibrillation threshold. Integrated lead have been designed with a greater distance between the distal coil and the lead tip, which is usually a 12 millimeter. This greater distance between the tip and the coil has resolved post-shock sensing problem, with the trade-off is increased risk of oversensing of far-field signals. Although having two coils in ICD leads offer modest advantages in terms of lowering defibrillation threshold, but disadvantages are still exist. This slide shows the image of typical lead designs. Although having two coils in the ICD leads offer modest advantage in terms of allowing lowering defibrillation threshold, disadvantages still exist when lead extraction become necessary. The proximal, which is a superior vena cava coil, is often densely adherent to the SVC and may be difficult to remove. Greater distance between the tip and coil associated with oversensing. and the lead diameter is large with single coil. Clinically, single coil systems are favored in young patients who have a potential need for future extraction, although EPTFE coated leads may mitigate the disadvantages of dual coils. True bipolar sensing is preferred in pacemaker dependent patient in the setting of abundant lead and for patient who may be at a risk at increased risk for exposure to electromagnetic interference. Dual coil system may be preferable when higher defibrillation threshold are anticipated, example in hypertrophic cardiomyopathy, anti-arrhythmic therapy, or some sodium channel defects. In general, larger devices have greater battery capacity and thus greater longevity. Patient size, particularly in smaller patients or children, may rarely constrain the site of device placement because of either limited pectoral tissue to support the device or cosmetic concern. In these situations, the option available are smaller devices with shorter longevity. Subpectoral placement and less commonly used site may be used. When device size become a significant factor, the technically simplest solution may be to use the smallest available device and insert it in prepectorally, despite potential limits to longevity. Even with the selection of smallest device, alternative insertion sites may be preferable at times. The single most important decision in selecting a defibrillator is determining whether to implant a single or dual chamber system. The decision may be influenced by several considerations. They are the need for a dual chamber bradycardia pacing, particularly in sinus node dysfunction, which is the strongest indication for dual chamber devices, and specific consideration that may respond to dual chamber pacing, example long QT syndrome or hypertrophic cardiomyopathy. The next is a significant left ventricular dysfunction. Assume that the patient not a candidate for a CRT, in which case a CRT-D would be selected. Next, the patient in whom medication that impair chronotropic functions are required, and paroxysmal atrial arrhythmias, improved specificity, that is differentiate supraventricular and ventricular arrhythmias, also a known ventricular tachycardia with a rate of less than 200 beats per minute. Since in this zone dual chamber reduction enhancement are particularly useful. The last is atrial therapy is needed, which is limited to device that include specific atrial therapies beyond pacing. Patient with chronic atrial fibrillation or patient who lacks the factor favoring dual chamber devices should receive single chamber defibrillator. This is particularly true for younger or smaller patient in whom the greater longevity per unit size and minimal intravascular hardware requirement of single chamber system may be more compelling. In addition to simplicity and longevity, single chamber device benefits include fewer complications. For patients who have infrequent pacing, who lacks episodes of atrial arrhythmia, and who do not have a specific condition warrant during dual chamber devices, or single chamber devices are preferred. In pacemaker dependent patient, true bipolar sensing is preferable. In chronic atrial fibrillation, single chamber device VVIR usually or rarely VVI. Paroxysmal atrial arrhythmia, dual chamber devices enhance specificity and lower risk of inappropriate therapy, particularly if VT is VT with a heart rate of less than 200 beats per minute or percent. Atrial pacing modestly reduces paroxysmal atrial fibrillation, especially in sinus node dysfunction, as long as ventricular pacing is minimized. In patient with atrial flutter with the previous heart surgery and incisional atrial flutter, atrial ATP may be useful. Atrial shocks are infrequently used in these patients. When anticipated, elevated defibrillation threshold, with documented previous high defibrillation threshold or hypertrophic cardiomyopathy or marked enlargement, may choose high output device with the dual coil lead. Usually, smaller body habitats, younger patients need a limited intravascular hardware. Smaller size single chamber is preferable. Consider single coil lead or EPTFE coated leads in these kind of patients. Pacemaker depend patient with very slow ventricular tachycardia. Consider relationship of upper rate limit to ventricular tachycardia deduction zone. Let's move on to lead and generator selection in cardiac resynchronization therapy. There are some specific consideration when selecting a generator, lead and device function when using cardiac resynchronization therapy devices. In order for patient to benefit, as close to 100% of QRS complex should be resynchronized, that is paced or paced with capture. CRT pulse generator require particular timing algorithm to maximize biventricular pacing, and LV pacing leads employ special design to maximize stability and minimize extracardiac stimulations. LV pacing leads should be sufficiently flexible in negotiating sharp angulation and tortuosity of venous system without traumatizing or dissecting the veins. Sorry. The lead must be large enough to wedge into the venous tributary, yet small enough to negotiate collateral veins, often requiring subcannulation to reach the LV free wall. Coronary venous leads should be maneuverable to any intramyocardial locations to decrease the likelihood extracardiac stimulation, and should be designed to allow multi-site or multi-vector stimulation. You can see in this slide the typical images of biventricular pacing leads for coronary sinus.
That's all for this lecture on generator and lead selection. Thanks for watching. If you found it helpful, please hit the like button and subscribe to Medfoxes for more cardiac pacing insights. Don't forget to take the short quiz. The link is in the description below to test your understanding. Stay tuned for the next lecture where we'll explore lead connection systems for CRM devices. See you in the next video, and as always, keep learning with Medfoxes.